In hypertensive patients, is better to start pharmacological treatment in monotherapy or in combination?
Well, this is a good question. I think for the vast majority of patients, it's recommended to start in combination treatment. The reason for this is that the vast majority of the patients we see every day in our clinics are patients at high risk. And this high risk is not due to the fact that they already had a previous myocardial infarction or a stroke. In the majority of patients, it's due to the combination of other cardiovascular risk factors and the progression of the silent disease. So in these cases, if you have other, for instance, obesity, hyperglycemia, and dyslipidemia, this combination of drugs of risk factors conferring the high risk needs combination therapy in order to reduce much more effectively blood pressure. Because in monotherapy it's almost impossible to normalize blood pressure in these patients. So the trend for the future is to recommend the use of combination therapy, starting at low dose, but increasing doses and even combining more drugs in order to achieve as soon as possible blood pressure control. Because the blood pressure control is important to be achieved as soon as possible if you want to delay the progression of the atherosclerosis and all the complications in the arteries induced by high blood pressure values.
Which drug should be included in the first combination strategy?
Well, the guidelines recommend the association of a drug blocking the renin-angiotensin system, that may be an ACE inhibitor or an ARB, with a calcium channel blocker or a diuretic, depending on the profile of the subject. If you ask me in which subjects you choose one or other, I have to say that for all hypertensive patients with risk of metabolic complications such as diabetes, for instance, all patients with obesity and higher values hyperglycemia, it's better to start combining with calcium channel blockers because calcium channel blockers are neutral concerning metabolic effects, and the blockade of the renin-angiotensin system is positive. So this combination is preferred and is recommended in the guidelines for all subjects with the metabolic syndrome and for subjects with diabetes. The problem is that in many of these patients, you will need a third drug to normalize blood pressure. If it's the case, the third drug should be a diuretic. So the combination of blockade of the renin-angiotensin system, calcium channel blocker, and small doses of diuretic are probably the best combination you can choose for a given patient.
And what are the advantages with the fixed dose combination therapies?
Well, I think this is also quite clear now because all the studies performed so far goes exactly in the same way. The number of pills matters in adherence to treatment. So when you are using fixed dose combination in single pills, you are reducing the number of drugs, of pills you have to intake, and then you are improving adherence. And adherence is crucial for persistence, long-term persistence on treatment, and then to reduce morbidity and mortality. So no doubt that fixed dose combination are better than free dose combination, and the main reason is the improvement of adherence to treatment.